In this part of my monologue on the esophagus, I'm going to be talking about generalized distension of the esophagus, or generalized megaesophagus. Megaesophagus represents a diffuse decrease in, or generally loss of, motility of the esophagus, and that's going to cause a diffuse dilation of the esophagus. Often it's gas-filled, although it can be fluid-filled or a mixture of those, and there can be some ingesta in there as well. Here's a typical appearance of a megaesophagus, where you have this broad area of potentially increased opacity or decreased opacity, depending on its fluid or gas. This is kind of a mix, resulting in ventral displacement of the trachea. So all of this is esophagus. It is profoundly distended, and this is a megaesophagus. This dog also has an alveolar pattern in the ventral lung field here, and so that would be consistent with aspiration pneumonia secondary to regurgitation from the megaesophagus. And so your diagnosis would then be generalized megaesophagus and aspiration pneumonia. There are a ton of different causes of generalized megaesophagus, so when you see one of these radiographically, you have a lot of differentials to think about. In a younger patient, you have to think about congenital megaesophagus, because that is hereditary and certainly is a problem. Lots of different acquired forms. Idiopathic is the most common, and we usually refer to it as idiopathic when we don't have a specific cause. Generally, it is a non-specific neuromuscular degeneration. Often it's associated with laryngeal paralysis as the kind of constellation of signs referred to as GOLP, G-O-L-P-P, or geriatric onset laryngeal paralysis and polyneuropathy. So it can be kind of in that generalized classification. Myasthenia gravis is one that's more specific and is certainly something we can test for, and is common enough that is definitely something to think about. But there are plenty of other possibilities for a generalized megaesophagus. Hypothyroidism, hypoadrenocorticism, esophagitis are all on the list. And don't forget about patients that you've recently anesthetized or sedated. They don't have a meaningful megaesophagus. It's not their pathology, but radiographically there is going to be, or certainly can be, esophageal distension that may fool you. So you do have to be careful about those patients. When there's a generalized megaesophagus, the whole esophagus is enlarged and tubular, and you see it best and most severely in the intrathoracic region rather than the cervical region, because there's more room for the esophagus to distend. And so you're going to see that really nicely on the lateral views, but you'll also see mediastinal widening on the ventrodorsal view. No matter what, the esophagus will taper as it gets caudally, into the region of the diaphragm, because it has to pass through the esophageal hiatus, and there's only so much room to work with there. In the most severe cases of megaesophagus, we will see an esophageal diverticulum that can extend into the more ventral portion of the cranial mediastinum and wrap around the trachea. That giant esophagus is going to shove other organs around, so most commonly we'll see ventral displacement of the trachea as long as the distension is severe enough. Other things can do that, so it's certainly not a specific finding, but it will be one of your helper findings to make your diagnosis. So here's a typical case of a generalized megaesophagus. You can see it's gas-filled. It is a big tube of gas back here. I can see the dorsal wall, I can see the ventral wall, and I should not be able to see that much esophagus. So there it is. Again, margins are easily identified, dorsally and ventrally. The trachea in this case isn't displaced as much. It's not quite a severe enough megaesophagus to do that. It takes quite a lot of distension to get to that point. This dog also has a little bit of an alveolar pattern ventrally, a few little patches down there. So once again, a patient with aspiration pneumonia and a generalized megaesophagus. And then of course we'd have to sort out what the underlying cause of the megaesophagus is. A much more severe case, this one we have ventral displacement of the trachea. You can see it's bowing down here. The heart looks a little squished. This is all esophagus up here. It's mostly gas-filled, maybe a little fluid, giving a little haze pattern to it. And even this extent down here is more of the esophagus, so this guy has a diverticulum as well. So just gigantic. You can see the esophagus is still tapering as it gets caudally because it has no choice if it wants to get through the diaphragm. So a very large diverticular component. Not as severely affected in this case, but just an example of where you can see As we move cranially to thoracic inlet, generally, even a fairly severely affected esophagus, distended esophagus, is going to taper, and ditto on the caudal side of it. The opacity in a megaesophagus varies. Air is most common, but fluid is second on that list. And again, depending on what the dog is willing to eat, you may see some ingesta in there as well. Air is maybe the nicest because it makes the margins of the esophagus most easy to identify. So this is same one from a few slides ago, where you get to see those nice edges really cleanly. This one has a bit more fluid in it, so I can certainly tell that there is a tubular thing up here. It is the megaesophagus, but the margins are not quite as discrete. I can identify one margin there, so I do see them, but it's a little bit of a tougher to see those edges because it's more fluid, kind of a mix of fluid and gas in this case. There are a few other kind of secondary findings that you will identify that help you make the diagnosis. So being able to see the longus coli muscles is a hint that there is gas in the esophagus, usually in a gas distended esophagus. Here's a normal dog. The longus coli muscles live right up here. I'm going to go back a moment. I don't see a discrete margin. I obviously see the margin of the trachea, but I don't see any further margins, so that's very normal. No extra edges where those muscles are. Compared to this dog with a megaesophagus, a gas-filled megaesophagus, now we have this really sharp edge that I don't expect to see. The soft tissue up here represents the longus coli musculature, so the fact that I can see that edge is abnormal and indicates that we have at least gas in the esophagus and most likely gas in a distended esophagus. Tracheal stripe sign is another one you'll read about, and it's not specific, but it is something to look for. Normally we don't see the outer serosal margin of the dorsal tracheal wall, and so when there is gas in the esophageal lumen, it actually creates a margin where we can get the impression that we're seeing that dorsal margin. It's not quite that simple, because that margin that we end up seeing with the tracheal stripe actually represents the summation of the ventral esophageal wall and a dorsal tracheal wall, but it's still called the tracheal stripe. Now, here's the key yellow, could have a hashtag with it, finding. A tracheal stripe sign is not specific for megaesophagus. It indicates that there's either gas in the esophagus or gas in the mediastinum, so it's not even specific for esophageal gas, but it indicates there's gas in one of those two structures. That's key point number one. And it does not indicate that there's distension. That's key point number two. So there's gas in the mediastinum or there's gas in the esophagus. Either one may or may not be distended. So again, not specific, but it's something that should make you think a little bit. Here's our normal dog again. I can see the dorsal edge of the trachea where the gas stops, but I really don't see a discrete tracheal wall very well up here. Compare that to our go-to gas-filled megaesophagus dog. Now I see a very nice sharp edge of the wall on the dorsal margin of the trachea. So that is our tracheal stripe sign. In this case, it's due to a distended esophagus, an esophagus that's distended with gas. But again, remember, you can see a stripe even if the esophagus is not distended, and you can see a stripe with a pneumomediastinum, not even gas in the esophagus. So you do have to be careful with this finding and use it in conjunction with other findings to make your final diagnosis. With a generalized megaesophagus, survey radiographs are sufficient. I say generally there, but in reality it's pretty much universally sufficient if there's a true megaesophagus. You don't want to give contrast medium. We know that if the esophagus is generally distended, that the motility is terrible. So putting contrast medium in there is not going to prove anything. We already have that indication. And you increase the risk of this dog regurgitating and aspirating whatever you put in there. So if you see a megaesophagus, you know the motility is terrible, you are done with your diagnostics as far as imaging goes. Now you just have to work up underlying causes of the megaesophagus. And then, like I've said before, the one caveat, the one main area to be careful about is in a patient who's recently sedated or anesthetized. The esophagus doesn't always, but certainly can dilate and might lead to a misdiagnosis of megaesophagus. So in a patient who you've sedated or anesthetized recently, if there's any question, let the dog wake up for a few more hours, re-radiograph that thorax and see if the esophagus is still dilated, in which case you need to be more concerned, or if that has gone back to normal, in which case it was just a result of your anesthesia or sedation. So that's it for megaesophagus in the generalized sense. We will move forward in the next round with further diseases of the esophagus.